So we're going to have a very interesting debate because we both prepared different topics. So I think that means I win, but I just wanted to start with that because I'm going to win my topic. So the little difference, the nuance that we had was that Dr. Still focused on the primary bariatric procedure, and I focused more on the revision patient. And does eating behavior really matter when you're looking at the situation of a revision candidate, and does it matter in the outcome? And it really is a different topic. I'll start with just a few comments about his thought process for the primary procedures before I dive into the revision arena again. But my comment would be that it certainly is nice to take care of patients that have made serious efforts to control their weight. The reason for that is that you get the sense that patients are compliant if they can focus on long-term efforts to control their weight. And I certainly don't object to the idea that we like patients who are working towards that long-term goal. The frustration is that when we have literature that suggests these procedures are safer, when we have literature that suggests maybe the results could be better, at least in my world, where we depend so much on the insurance companies to tell us what we can do, they start to use that information against our patients and basically start to mandate these things. And all of a sudden, we're left struggling with patients who certainly have made long-term efforts to control their weight, but now they're frustrated because they have an insurance requirement that's going to put them in a situation where the next 12 to 18 months, they can't move forward with medically indicated treatment, i.e. bariatric surgery treatment, because they now have to demonstrate their compliance with efforts to lose weight. And that's really where the concept breaks down. I will certainly admit to having required patients to make an effort at weight loss or to accomplish weight loss as a risk reduction strategy for surgery. I think it's a useful risk reduction strategy. However, I do not believe that we should make these things routine in our care of patients, because there are consequences to making those approaches routine. So let me shift now a little bit to the discussion of the revision patient, and I want to talk just for a moment because my position on this is that eating behavior doesn't really influence the results of revision surgery, and the reason for that I'm going to start with is right up front, which is the world of conversion when you're doing revision. And now conversion means that we're going to take a patient from one bariatric procedure to another bariatric procedure. And conversion surgeries have been done throughout the history of bariatric surgery. When you go back to look at jejunal-ileal bypass, when you go back and look at various gastroplasties, when you look at vertical banded gastroplasty, and then in the most recent generation, the adjustable gastric bands, conversion to another procedure. And quite frankly, you know, I don't think it's worth, you know, spending a lot of time working on the patient's eating behavior, because they typically, their behavior is being controlled to some extent by the operation that they previously had. So when you're looking at doing conversion surgery, you're really looking at a patient who has what you feel to be pretty normal anatomy for that previous procedure. And that's important because if you didn't think the anatomy was normal, you might not consider conversion, but rather correctional surgery or revisional surgery of the abnormal anatomy. So here, for example, one of the more common things that we see today is we have a patient with a lap band, and we do the workup, we do the EGD, and we do the contrast studies, and we take a look and we say, well, this lap band looks fine. And yet the patient remains or has recurrence of morbid obesity. So when you're looking at doing conversion, you're basically recognizing that various operations provide different results in different patient groups. And now we're getting to the meat of the matter in terms of patient selection. You know, do you reach out and try to help that patient who's not done well with the previous operation by giving them, hopefully, a more appropriate procedure for them, or a more metabolically powerful operation for them to help them control their disease? So I would be overly concerned about judging the patient's behavior in that situation, particularly when we know the operation that they had previously was a relatively weak operation in terms of the metabolic power of the operation. So essentially in conversion, we just basically say the procedure that was done was not the right procedure for this particular patient, whether it was known in forward-thinking manner or a retroactive thinking manner. That's what we decide. Not effective enough for this patient's disease process, maybe complications, created trouble for the patient, worked for a while but isn't working anymore. And we should pause on the issue of a complication because, again, when you get to interface with the insurance companies and try to help them understand the medical decisions, how frustrating is it when you have a patient who's got a problem from their previous operation and you want to do a different bariatric operation to get the patient out of trouble, and because of my good friends like Dr. Still advocating for mandatory weight loss efforts, they're telling me my patient now has to go on a diet for 12 months before I can rescue them. How frustrating is that? But that's the way these folks think. So in the setting when the anatomy is not normal, we look at doing revisions or repairs, correction of the anatomy, and I do think in this situation we probably have to make a bigger attempt to judge the eating behavior to predict the results. So eating behavior issues in this population listed here, all sorts of problems: overeating, continuous eating or grazing, eating the wrong things, high-fat junk food, sweets, carbs, all these things. As we know, the problem with the sugar and liquid calories and so-called slider foods is they slide down without giving you much feedback in terms of your surgical procedure, particularly with the restrictive part of the procedures. So this is a test that I have started to use when I talk to patients. I call it the sub-sandwich evaluation. And what I do is I ask patients, and it's amazing to me how many people know this answer. I say to them, when you go to the sub shop and you order a sub sandwich, you know, with the big thick bread, how big a sandwich do you order? Everybody knows this answer. I can't believe it. But they'll say, oh, I order a 6-inch. I order a 12-inch. I order a 6-inch and I have to cut 2 inches off and then I can eat it. But it turns out to be somewhat quantifiable, interestingly. And so what I would say is that this is usually a pretty dense meal, and it gives me a poor man's estimate, if you will, of the capacity for that patient to eat. And yes, I know it seems crazy, but I have patients who tell me they can order a 12-inch sub sandwich with the bread and eat the whole thing in a reasonable amount of time. And I don't think that's compatible with most of our bariatric operations that we know today. So I look at it as a way of assessing the situation. Other factors that are at work here are the concepts of hunger and satiety. I worry a lot about a revision candidate who tells me they don't eat because they're hungry. And I'm not sure I can figure out how to fix that problem. Because if you're doing what we might call mindless eating, and you're eating by the clock, but you're eating enough without hunger that you've become obese again, I don't know that I can repair that situation with a surgical procedure. So I always ask if patients have that drive, that hunger drive to eat, and I worry about more psychological factors when the patient says, no, I don't experience hunger. And then my next question is, well, why do you eat? You know, how simple is that? So I've classified eating behavior. I've looked at this in terms of gastric bypass patients. I've kind of felt there's maybe 4 categories of eating. I look at this class 1, this is in terms of quantity and even the physiologic responsiveness of the operation. I think class 1, in my view, is typical of the early post-op bariatric surgery patient who can really only eat very small quantities, feels full with really small quantities, and has a very physiologically active operation, particularly with gastric bypass. So this is the patient who tries a little bit of sugar and gets a bad dumping episode. So very sensitive in that way. So the second part of the assessment from my perspective is for a revision candidate to then try to correlate the eating behavior with the anatomy and to try to figure out if the anatomy and the behavior are concordant or discordant. And class 1, again, little to no hunger, eats by the clock, very restricted 1 to 2 ounce meals. Class 2, some hunger, a little larger eating capacity. Class 3, now we're getting into the 6-inch sub-sandwich range, so fairly significant capacity and significant hunger. And then class 4, these are the patients who feel like they never had bariatric surgery now. They don't feel limitations when they eat. They don't have dumping at all, no matter what they eat. And they've got recurrence of comorbidity like diabetes and so forth, and they're always hungry. So this is the description of the concordance down here at the bottom, this idea that patients, if the anatomy and the behavior are concordant, an example would be the patient's got dilated anatomy, dilated proximal gastric reservoir pouch, and large eating capacity, large volume eating capacity. To me, that's concordant. Now, I'll admit there's another group of patients. There's a group that these things are discordant. For example, I look at the anatomy and it looks dilated to me, and then I go back to the behavior and I talk to the patient, and what I'm hearing is they feel very restricted, and they don't eat any of the bread on the sub sandwich because it's too much, and they have to eat only part of the meat because they get full. And maybe they're doing things like ingesting liquid calories and sugar, and it's not causing dumping. But then again, I tell patients all the time that we can't add more restriction to your operation and expect your problem to get better with obesity if we're not targeting the right issue. And I feel that patients can drink liquid calories after a revision without any problem at all, without a sense of fullness. So I would say that there is an influence on eating behavior and decisions about surgery, particularly in the revision situation, but primarily focused on that subgroup of patients where you're looking at revision as compared to conversion. So I would in part agree with Dr. Still, but completely, and certainly not in the primary bariatric operation scenario. So thank you very much.
Well, I just want to rebut one thing. Very nice talk, by the way. I'm sorry that we don't mandate the weight loss on everybody. You have to look at your population, I think. The average BMI that the surgeons operate on is 51 with a lot of disease burden. So a modest weight loss for everything I went through is helpful for that. If they can't lose weight, we don't ban them from having surgery. We do suggest it. But I think it helps us to try, as I said, try to pick the right procedure, pick the right primary procedure, because I think you'll do less revisions if you spend some time doing that. And also, if they have problems preoperatively, we can intervene early postoperatively. So I agree with the ASMBS statement of I don't think there needs to be a 6-month mandated diet and weight loss, but don't poo-poo a little bit of modest weight loss preoperatively.
Well, and just a further refinement of that discussion, Dr. Still, which would be that that what I've learned from our health insurance companies is that they may have these policies up front, which is what you get to read, but when you look at how the policies are developed, there is always physician input into the development of the policy. And so they look at studies like Dr. Still has shown you to show better outcomes and the value of preoperative weight loss. And then they take that idea and they say, well, we can't trust the doctors to make a decision about this. We're going to take this over and we're going to mandate how you have to approach the bariatric surgery candidate. And so they take that and it gets kind of twisted around, and all of a sudden it becomes a mandate instead of a medical decision. So I really want to point out the difference between whether the motivation for the preoperative weight loss is the care team, whether it's the medical bariatrician or the surgical part of the team, but making an intentional decision to do preoperative weight loss for the purposes of improving the patient, maybe testing the compliance. It's not an unreasonable explanation for why you would do that, or to reduce the surgical risk. I have no problem with that approach. What I have a problem with is how this has all been twisted around by the health insurers to make it a mandate, and therefore, yeah, so we're not really going to fight about this because we both agree, but we have to put on a little bit of a show. So thank you very much.